Hi everyone, so creating another lecture video here for you to continue out and finish out our chapter 16. I am kind of changing camera angles here to try to get not so much of a glare in my glasses. Gotta have glasses on because I gotta see, and currently the ophthalmologist is not open and I am running freshly out of contacts. So glasses here for a while for me for the next little bit, but trying to keep the glare and all of that out of your way. So when we left off yesterday, we were talking about the different targeted anti-cancer cells. So now we're going to go ahead and talk about the investigational therapy. So investigational drugs are medications that are not yet approved by the Food and Drug Administration, and they are being studied as part of a clinical research program. So this kind of ties into what you've been learning in chemistry. We've been learning about the informed consent and all of those different aspects of a clinical drug trial. Expanded drug access, I think we may have gone over this a little bit, but it doesn't hurt to recap it here. So these expanded drug access or access drugs are used for a particular investigational agent for a specific disease outside of the clinical trial. So sometimes we have a specific drug that is being used for one clinical trial, and they're kind of seeing some benefits for other areas, and so they'll start an additional clinical trial for a different indication that the drug wasn't even originally developed for. Again, the approval is granted on a case-by-case basis, and only treatment of serious medical illnesses or life-threatening conditions. So these are things that patients are suffering from that are very serious medical conditions that have no cure, and illnesses that are life-threatening. We talked about accidental exposure, we talked about PPE, we talked about spill kits. So my goal is I have to go into PMI tomorrow and do some paperwork and stuff. I'm going to grab a spill kit while I'm there, and hopefully I can get that here so we can do a video on the spill kit so you can see actually what is contained within the spill kit. We talked about the SDS sheets. We have an SDS in the classroom. Again, it's not as full and as extensive as what you would see in a real pharmacy setting. But you get the idea of, even in the classroom, we do have items or ingredients or products that are dangerous to us, bleach probably being the most dangerous one in the classroom that we have. But we have the SDS there. It's required by OSHA, it's required by our accrediting bodies, and that is in the event that you have an exposure, a splash in the eye, you get somehow in your mouth, we know how to get you help and treatment. So preventing chemotherapy-related medication errors. This is huge. Think about how toxic the chemotherapy medications are. Any medication error is a problem. Any medication error can be a fatal error, but especially when we're dealing with chemotherapies. Those of you that have gone through law, you heard the Emily Jerry story and how the use of the wrong sodium chloride to make the chemotherapy bag resulted in the death of a 2-year-old child. That is probably the most famous medication error story. It is a true story and a very sad one, but it also ties in specifically with chemotherapy. So prescribing errors, okay? So these are errors that come in place when a prescriber makes an error. So a physician makes an error in the ordering process. Transcription error, okay, these can be errors that occur from either a pharmacist or a technician that are doing order entry. So the order is incorrectly transcribed into the dispensing or computer system. So if you're working in a facility that allows technicians to do order entry and you are tasked with putting a chemotherapy order in, you need to treat that just as you would any other prescription order entry process and make sure that you are entering that completely completely accurately. Preparation errors. So a chemotherapy agent is incorrectly prepared. So in the case of Emily Jerry, and I'm going to attach that podcast for you guys to listen to in this chapter. So just so you can hear kind of the story behind that and what happened. It does go in great detail about how the pharmacy technician chose the wrong sodium chloride and how that inadvertently led to the bag being made incorrectly, and the little girl did end up passing away a few days later. I highly encourage you to listen to the podcast, and it kind of puts a sense in how important and imperative our jobs are to make sure that we're ensuring our patients' safety. Administration errors. So the chemotherapy agent is incorrectly administered. So this is typically from a nursing standpoint or a caregiver standpoint or even a patient standpoint. If they're getting toxic or chemotherapy drugs through a retail setting, like tamoxifen or methotrexate, those type of things, they're self-administering. So having these patients see a pharmacist and getting that counseling is imperative, so they understand how, when, why, how, where, all of those that tie into how they take the medication. From a hospital standpoint, we prepare the medication, we deliver it to the nursing unit, and the nurse is the one that is going to be administering that medication. So errors can happen there as well. If they hang the wrong bag or they run it at the wrong time interval or things like that. That's how those errors occur. So preventing these type of errors, so inventory and storage measures to prevent chemotherapy errors. So typically in every facility, chemotherapies are kept completely separate from regular prescription medications, including injections and vials. Not storing any look-alike, sound-alike drugs next to each other. That includes chemotherapies. If there's two chemotherapies that are similar in name, similar in sounding names, they need to be kept separate. Affixing look-alike and sound-alike labels to certain medication containers, that is especially helpful for our nursing staff. You're giving them a heads up of, this patient has more than one drug. These two drugs sound alike, look alike. Be aware, watch which one you're giving to make sure it's the right one. Using color-coded or labeled storage bins. When I worked in the hospital in Albuquerque, we had three colored systems. Our regular prescriptions were kept in regular, probably I'd say pale brown bins. Our high alert meds were kept in red bins, and all of our sound-alike lookalikes were in yellow bins. So as we were pulling medications from these specific bins, it was a second double check for us of, I'm pulling a sound-alike lookalike med. I need to make sure I have the right one. Following manufacturer's warning on hazardous drug products. So these warnings are essential. These warnings include information that needs to be given to the patient. This includes handling. How do we as technicians handle it? How do we tell patients to handle it? How do we tell our nursing staff? How do we store it? Do they need to be refrigerated? Can it be kept at room temperature? How long are these preparations good for once we make them? And then notice tall man lettering on the medication labels. So again, I've shown you vials in the pharmacy that we have of real empty but real prescription drug bottles, and you have seen the difference in when they use the tall man lettering versus when they do not. So everyone on the healthcare team plays a role in preventing medication errors with chemotherapy drugs. The pharmacy technicians should be deliberate and methodical, and should implement checks and balances to ensure the safety of the patients as well as themselves. So not all states have check states, or check states. It's a mouthful, and it's Thursday, sorry. So check states where pharmacy technicians can check one another. Arizona is not one of those states. You must have a pharmacist final verification before anything leaves the pharmacy. but it's not uncommon, and it's actually encouraged that if you're compounding or preparing IVs or dispensing any medications, especially chemotherapies, high alerts, anything like that, that, ask for a second opinion. Call one over your fellow techs over there and, hey, Lisa, hey, can you take a look at this for me and make sure I pulled the right one? That's okay. It's a double set of eyes. Nothing can be hurt with that. So what are some of the inventory and storage measures that we as healthcare professionals or personnel can take to prevent chemotherapy errors? So again, that's just storing sound-alike, look-alike separately, labeling the sound-alike, look-alike medications using color-coded bins or color-coded stickers, following the manufacturer's warnings for not only storage but also handling, and then paying attention to any of the tall man lettering on the manufacturer's prescription bottles. So we're getting towards the end here, so we're almost there. You guys have done a great job. Complementary and alternative therapy. So the rationale for seeking alternatives. So sometimes patients will seek alternatives because they feel like they're having they sense that they're losing control when they're diagnosed with a terminal illness or something like cancer. Sometimes it's not even cancer specific, or it's a certain disease that is not curable but progressive, like heart disease, COPD, those things that aren't curable, and over time they will progressively get worse. So they feel a sense of loss of control. So they start seeking other options that they have the control of. Well, I read that taking this supplement helps these diseases, so I'm going to take this. They're trying to regain their control. Preference for non-traditional approaches due to a lifestyle or belief system. This ties back into our cultural, being culturally sensitive to our patients and where they're from, what their cultures are, and what their religions are. Some cultures and religions choose not to use Western medicine. They choose not to participate or accept chemotherapy treatments, and they choose to solely go off of alternative therapies. That's their right. They have that right to choose that, and we have to be supportive of that. Range of effects. So sometimes these complementary or alternative therapies are used to help relieve symptoms. So they're not using it to treat the cancer. They're using things like ginger to help with the nausea and vomiting, or aloe to soothe the skin if they've had radiation therapy, things like that. Sometimes they're harmless. Most of the complementary or alternative therapies are harmless. But in the event that we have to be careful and let our patients know that they should always alert their physician or their pharmacist of any additional complementary or dietary supplements, natural supplements that they're taking, to ensure that there's not going to be any interactions with the drugs or the chemos that they're taking. Sometimes there's significant toxicity. So when you think about toxicity, think about how, for example, our vitamins, we have water soluble vitamins, and we have fat soluble vitamins. Our water soluble vitamins we can consume in large quantities. Our body will use and absorb what it needs, and the rest is going to be excreted out in our urine. Fat soluble vitamins, not so much the case. So vitamin A, for example, vitamin E, these are not water soluble. So there's a daily recommended allowance for a reason. If we take higher amounts of vitamin A, higher amounts of vitamin C, those excess amounts are stored in our fat, and over a period of time we build up toxic levels. Negative impact on traditional cancer treatment. So again, it comes into play that sometimes these patients have to make a decision on whether they're going to choose traditional Western route as far as chemotherapy treatments, radiation treatments, or if they're going an alternative route. And the reason for that is many times that these two cannot go hand in hand, and that's because of the interactions between the supplements or the dietary supplements or the natural products versus the chemo drugs. And that's it. We have finished this chapter. You guys have done a great job. Again, just a few reminders. I have some of you that are not participating in the discussion board, or you've just posted one thing. Go into your Tuesday folder for both courses, access that discussion board, get in there and look at what you've got going on. You've got an initial post for Tuesday and then a response to each to one classmate each day, Wednesday, Thursday, and Friday. And Wednesday and Thursday, I've posted new questions, so you have a response to those as well. I did make an announcement for pharmacology that because we are not having our final exam next week, that I've changed the dates for the drug quizzes. So your integumentary or skin drug quiz second half is going to be on Tuesday, and then the immune system second half is going to be on Friday of next week. So I did ask in the announcements that you shoot me an email to acknowledge that you heard that, or that you read that, so you know those changes that have happened. You guys are doing a great job. Keep up the hard work. Your assignments are coming through beautifully. A lot of you are using either a different color or a bold font on your assignments, and thank you. That has helped me in the grading process, kind of cut the time down a little bit, so thank you very much. I am going to continue videos throughout the weekend for next week. I will do videos to recap chapter 4, 5, and 15. And so hopefully go back so you guys can review through there. I will get a final exam review up and loaded for you guys by the end of next week, so you'll have that. So when the time comes that we're back on campus and we're going to have our exams, you'll already have your review in place. If you have any questions, be sure to email me. And if not, have a good rest of the day.